Hi, this is Dr. ROJoson, Director of the ROJoson PEP Talk. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the core course on October 9, 2021. From October 23, 2021 onwards, I have started tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of Cancer, which is part of the cancer course. The empowerment objective is for the lay people to have an understanding of the fundamentals and generalities in the medical management of cancer. Some definitions of terms in the title. Fundamentals mean the basic principles, foundation, basis. Generalities, majority, not all, not detailed, not specific. Medical management of cancer refers to diagnosis and treatment of cancer by physicians. The contents of this talk will be the following: screening of cancer, symptoms that will lead to suspected presence of cancer, clinical diagnosis of cancer, and paraclinical diagnostic procedures for cancer. This will be covered in this talk today. Part 2, which will be given next week. The contents will be treatment for cancer, surveillance of cancer, prognosis of cancer, and palliative and hospice care for cancer patients. Let's start with screening for cancer. Screening for cancer means looking for a cancer that may be present in apparently healthy and asymptomatic persons. The general screening methods consist of the following: risk assessment interview or evaluation, risk assessment interview and physical examination, risk assessment interview and physical examination with the use of instrumental or laboratory diagnostic procedures. Let's start with the risk assessment interview or evaluation. This is done to look for higher risk for cancer in a particular patient or person, example, family history of cancer, risky lifestyle and behavior such as tobacco use, unsafe sex, sharing needles, excessive sun exposure, etc. If positive for higher risk, the recommendation is to proceed to symptom sign evaluation or physical examination, and if indicated, do instrumental or laboratory diagnostic procedures. If negative for higher risk, may stop here or proceed to symptom sign evaluation, which consists of interview and physical examination, to complete the basic essentials of screening. The second method, general screening method, is risk assessment interview and physical examination. This constitutes the basic essentials of screening. So, if positive for higher risks, and if with suspected presence of cancer based on symptoms and signs, proceed to instrumental or laboratory diagnostic procedures as indicated. If negative for higher risk, and with no suspected presence of cancer based on symptoms and sign, may stop here. The third general screening method is risk assessment, interview, and physical examination with the use of instrumental and laboratory diagnostic procedure. The recommendation is to do instrumental or laboratory diagnostic procedures only if positive for higher risk for cancer and or with suspected presence of cancer based on symptoms and signs. In this era of commercialism in medicine and healthcare, beware of a lot of hospitals and laboratory clinics peddling screening packages for cancer. Don't be swayed easily by the marketing and discount offers. Let's go to the second topic, which is symptoms that will lead to suspected presence of cancer. There are more than 200 types of cancers. The 200 types of cancer is not equated to 200 set of symptoms that have to be memorized for purpose of early diagnosis. So let's try to simplify things for efficient early diagnosis as well as for patient empowerment purpose. First, classify the cancers into solid and liquid cancer, and then the organs and tissues of origin. So let's try to use these classifications to make a simple to remember list of symptoms that will lead to suspected presence of cancer. Let's call these symptoms as alert symptoms or symptom cues. So first, know the alert symptoms or symptom cue for blood cancer, or blood cancers are also called liquid cancer, and then non-blood cancer or solid cancers. The alert symptoms or symptom cues for blood cancers are those associated with blood disorder causing symptoms such as unusual easy bruising, unusual bleeding tendency, and red spots on the skin. The alert symptoms or symptom cues for solid cancers are those associated with a mass or buccal disorder causing symptoms. So one of the alert symptoms is a palpable or multiple masses or buccal in the superficial organs and tissues. The other alert symptoms that may be caused by a mass effect in the internal and deep organs and tissues. Example, headache, in the brain tumor, cough, lungs, hoarseness, larynx, difficulty in swallowing, can be esophagus or stomach, change in bowel habit, intestine, or colon. The other alert symptoms under the mass effect will be the symptoms that may be caused by an unusual negative event in the mass, such as pain coming from the mass, bleeding, and discharge. Examples are headache, vomiting of blood, coughing of blood, passage of blood per anus, unusual vaginal discharge, etc. In the internet, one commonly sees these warning signals of cancer. I don't know who originally created this, most likely in the USA. The warning signals started with 7. Some centers now give as many as 17 signals and even more. So this is an example of a warning signals for cancer from the University of California, San Francisco, with 17 warning signals. These 7 warning signals of cancer is a simplified infographic focusing on the more common cancers in the community and their common alert symptoms. Change in bowel or bladder habits. This could be symptoms cue for bladder and bowel cancers. A sore does not heal, skin cancers, unusual bleeding or discharge, any cancer in the hollow organs, thickening or lump in the breast or elsewhere, mass or buccal anywhere, indigestion or difficulty in swallowing, esophagus and stomach cancers. Obvious change in the wart or mole. This could be a symptom cue for melanomas. And nagging cough or hoarseness, symptom cues for lungs, laryngeal, and thyroid cancers. So this UCSF, or University of California, San Francisco list of 17 warning signals of cancers is more comprehensive and specific, but it still cannot be said to be complete. But the challenge is really how to remember all of these 17 warning signals. So my suggestion, one may use the 7 warning signals of cancers, more than 7 warning signals of cancers that are available, and the ROJoson alert symptoms using symptom cues for cancer, okay, on using 2-step algorithm, cues for liquid and blood cancer and cues for solid cancers, and then for the latter, the solid cancers, look for symptoms cues for a mass effect, and mass events. Let's now go to the third topic, clinical diagnosis of cancer. Before I go further into the discussion on clinical diagnosis of cancer, which is the first thing that a physician does in medical management, let me say, I utilize this framework of patient management process, which I have discussed before, and which is applicable to all kinds of patients and all kinds of medical concerns, whether cancer or not. Clinical diagnosis means a conclusion or decision made by a physician after examining a patient and after evaluation of the data on symptoms and signs. Symptoms are what are felt and observed by the patient or a person on the body, and signs are the findings of a physician after physical examination of a patient. These are the procedural steps in the clinical diagnosis of cancer, starting with patient consulting with symptoms, and then the physician evaluates the symptoms to see if these are alert signals or symptom cues for cancer or not. Then the physician does physical examination to look for sign cues for cancer. And then the physician processes the symptoms and sign to determine whether cancer is present or not, arriving to a clinical diagnosis with a conclusion or ending on the following: not cancer, cancer suspect, probable, most probable. The processes used in the clinical diagnosis of cancer are pattern recognition and prevalence. Pattern recognition process means realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Prevalence process means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age and sex group, and in the affected organ and systems. I will now give examples of symptom and sign cues and the use of pattern recognition and prevalence in the clinical diagnosis of cancers. Blood cancers exemplified by leukemias. So the signs and symptoms, or symptoms and signs in leukemias, are non-specific and which are variable, with the following as common symptoms and signs listed down here, but with the underlying ones as particular cues: easy bruising or bleeding, recurrent nosebleeds, tiny red spots on the skin or petechiae, frequent or severe infections. The more common non-specific signs and symptoms are fever and chills, persistent fatigue, weakness, losing weight without trying, swollen lymph nodes, enlarged spleen, liver, excessive sweating, especially at night, and bone pain or tenderness. Breast mass in the patient 30 years old and above with a palpable mass. If the mass is solid without fixation, meaning it's movable, okay, and no armpit, so the patient is a breast cancer suspect. Now, if the solid mass is accompanied by fixation to the underlying or overlying skin, meaning it's not movable, but without armpit lymph nodes yet, the patient is a breast cancer probable. Now, if the mass is solid, fixed, and with armpit lymph nodes, then the patient has a breast cancer most probable. Again, another patient, any age, with a palpable breast mass, but this time the mass is cystic, not solid. When you say cystic, containing fluid, so the clinical diagnosis is not a breast cancer suspect, it's benign. Specifically, it's a macrocyst due to hormonal change. Another patient, any age, with palpable breast mass, with redness, tenderness, and possible pus formation. So the clinical diagnosis is not breast cancer suspect, benign. Specifically, there's infection and abscess going on. And a patient with a thyroid mass, any age, any sex, palpable thyroid nodule or mass, if the mass feels solid and hard with no neck lymph node yet, with no hoarseness of voice, then he or she could be a thyroid cancer suspect. If the mass, aside from the feel of solidity or solidness and then hardness, is accompanied by palpable neck lymph node, then the diagnosis is thyroid cancer probable. And then with hoarseness of voice, which is a sign of invasion, if this is present together with hard, solid, and lymph nodes, then the patient should have a diagnosis of thyroid cancer, most probable. Thyroid mass, any age, any sex, but the mass is cystic, containing fluid. So the clinical diagnosis is not thyroid cancer suspect, benign. The specific diagnosis is colloid cyst. So remember the definition of cancer when evaluating a mass, for you to remember the so-called pattern recognition. Cancer is a medical disease when some of the body cells grow uncontrollably with the potential to invade the adjacent body tissues or organs and to spread to distant sites like tissues and organs. So suspect cancer in a mass with use of invasion of adjacent tissues, as represented by the findings of ill-defined border and fixation. Suspect cancer in a mass with use of spread to distant tissues or organs. Again, let me just repeat again the procedures in the clinical diagnosis of cancer. Patient has symptoms. So what will the physician do next? The physician evaluates the symptoms to see if these are alert signals or symptom cues for cancer or not. The physician does physical examination to look for sign cues for cancer. And lastly, the physician processes the symptoms and sign to determine whether cancer is present or not. Not cancer, cancer suspect, probable, most probable. So at the end of the clinical examination, the physician makes a clinical diagnosis. These are the possible conclusions or decision again: not cancer, cancer suspect, cancer probable, cancer most probable. So the next thing for the physician to decide after the clinical diagnosis is whether to do paraclinical diagnostic procedure or not, whether to do instrumental or laboratory diagnostic procedure or not. So let's now go to paraclinical diagnostic procedure for cancer. The foremost indication for a paraclinical diagnostic procedure can be stated this way. If you are not certain on the primary clinical diagnosis and you need to be certain and be more certain before treatment, then go for a paraclinical diagnostic procedure. To decide on the indication of the paraclinical diagnostic procedure, the physician uses two processes: the degree of certainty on the primary clinical diagnosis and comparison of treatment plans for the primary and the secondary clinical diagnosis. As a rule, if there is no need for paraclinical diagnostic procedure if you are quite certain of your primary clinical diagnosis, and the treatment plans for the primary and secondary diagnosis are the same. So these are general rules. If there is a need for a paraclinical diagnostic procedure, the physician uses the BRCA processes. B stands for benefit. Okay. The goal is to be more definite on the diagnosis. The risk, R stands for risk, C stands for cost, and A, availability. The physicians list down the various options of paraclinical diagnostic procedures and then gives data on the BRCA. With the data given, the patient is asked what he or she prefers. There are several issues to discuss in the selection of paraclinical diagnostic procedure to be done for suspected cancer. There are a lot of confusions, not to say errors, happening right now. The first issue is using PAD, using the popular paraclinical diagnostic procedure without comparative analysis in terms of benefit, risk, cost, availability of the other options, usually with no consideration of the cost effectiveness and patient preference. So this is not recommended. Number two issue is shotgun approach ordering every possible test just to catch a diagnosis. Again, this is not recommended. The third one is ordering tests not needed for the diagnosis of the cancer. Absolutely senseless and not recommended. The other issues that we have to discuss here on paraclinical diagnostic procedures are primary and secondary indications, direct versus indirect investigations of the suspected cancer. Primary indications refer to the direct information needed on the tumor or alert symptoms itself where cancer is being suspected. Okay. So these are the so-called primary paraclinical diagnostic procedures. Okay. So this is the first priority. It must be accomplished first. Okay. So primary indications for paraclinical diagnostic procedure for cancer consist of the following: not quite certain of the clinical diagnosis of cancer, at the moment just a suspect or probable. And number two, if there is a need to be very, very certain in the diagnosis of cancer because an extensive, complex treatment procedure is being planned. So these are the primary indications for paraclinical diagnostic procedure for cancer. Secondary indications refer to the other information needed in the planning of treatment if there is cancer. So secondary indications consist of the following: if there is a need to know before treatment the extent of the cancer and other information such as the specific cancer type and prognostic examinations. As I said, this is the second priority. If needed to be done, it should be done after the primary indications. Direct versus indirect investigations of the suspected cancer. Okay. Direct means done on the suspected primary cancer lesion itself, such as biopsy of the lesion. Indirect means done outside the suspected primary cancer lesion, such that if positive for cancer, will infer cancer on the primary lesion. So both approaches can be done as dictated by the situation. However, as much as possible, do the direct approach first. Do the second approach only if the direct approach is not feasible or difficult. So here are examples of physicians ordering for paraclinical diagnostic procedures. For blood cancer suspect, one example of a shotgun approach being done, doing complete blood count, blood cell examination, bone marrow biopsy, imaging such as CT scans and MRI in one sitting, in one ordering, okay, compared to a targeted sequential approach, okay, doing complete blood count first, waiting for the results, and if indicated, do the blood cell examination, and if indicated, doing a bone marrow biopsy, and if indicated, doing imaging such as CT scans and MRI. So the targeted sequential approach is recommended rather than the shotgun approach. For a patient with a breast mass suspect with the palpable mass, the shotgun approach usually being done, ultrasound of the breast, mammography, CT scan, tumor markers, bone scan, ultrasound of the abdomen, PET scan in one sitting, in one go. The target sequential approach with prioritization consists of breast mass examination, example biopsy with or without ultrasound, and then if indicated, doing examination for the extent of the cancer. This is the one usually recommended. So examples of BRCA, comparative analysis of paraclinical diagnostic procedures. Okay. So list down the options, 1, 2, 3, and then list down the benefits for each of the options. Example, accuracy is 99%, accuracy is 90% for option 2, and 60% for option 3. Example, the risks are all acceptable, and then but the cost is 4,000 for option 1, 3,000 for option 2, and 1,000 for option 3, assuming that all are readily available. So which should be recommended? So option 3 should not be recommended, okay, because the accuracy is only 60%. Okay, so the recommendations is either option 1 and 2, preferably option 1 if the patient can afford the 4,000. If she doesn't have 4,000, then you can go for option 2. Another example, a breast cancer suspect with a palpable breast mass. List down the options here of paraclinical diagnostic procedure: biopsy, ultrasound, mammography, CT scan. Okay. These are some examples of the information gotten or given. So biopsy can give you a direct information. It has a 4+ diagnostic yield. Ultrasound, indirect. Mammo, indirect. CT scan, indirect, because these are just imaging techniques. Okay. With the diagnostic yield of 2+ for ultrasound, 1+ for mammography, and 3+ for CT scan. Okay. On the risk column, okay, listed are the side effects or concerns of the patients with each procedure. So pain on biopsy, no pain on ultrasound, mammography, pain plus radiation, CT scan, no pain, but there is radiation. In terms of cost, CT scan is the most expensive, okay, with ultrasound being the least expensive, okay, and then assuming that all are available, okay. Then after this data are listed down, these are shown to the patients, and then the patient is asked what does he prefer or she prefer. Summary takeaway, I have discussed screening for cancer, symptoms that will lead to suspected presence of cancer, clinical diagnosis of cancer, and paraclinical diagnostic procedures for cancer. So this is what will be taken up in this particular lecture, part 1. So part 2 will be taken up next week. Takeaway in relation to patient empowerment. Be always in touch with reliable medical information on the fundamentals and generalities in medical management of cancer. Knowledge is power. It gives power. So use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of cancer. So with that, I end my pep talk, Fundamentals and Generalities in Medical Management of Cancer, Part 1. I hope I have empowered you, the lay people, to have a better understanding of the fundamentals and generalities in the medical management of cancer. Thank you for your kind attention. Mabuhay kayong lahat.